So you are Sean. Sean was it? Okay. Let's get the names right.
Alrighty, I'm going to start with the Pedra,
Okay.
and then if we have time, I'll get into Latinus a little bit and try to go through the circulation of information.
Okay.
Alright. How are you doing today, Doctor?
Good.
Thank you I'm doing good.
Okay.
Thank you for your time. I appreciate you sitting down with me, and I know how busy your time is and how important that is for your patients. And I'd just like to talk to you a little bit about your treatment algorithm when it comes to starting a patient on MDI, multiple daily injections. When, at what point would you try to initiate rapid-acting mealtime insulin?
Usually once we've tried 2 or 3 oral agents.
And then usually a basal. And
Right.
what type of insulins do you currently use? Any favorite insulin that you use as far as rapid?
For a rapid, probably most often
Humalog.
Yeah.
It's a great product. I used to sell it for several years for Lilly, and the nice thing about a Pedra, it has some competitive advantages, whereas with the Lispro and Novolog, because if you really think about Lispro and Novolog, you probably really can't think of many differences between the two, could you?
No.
And I couldn't really either when I was representative. I mean, we had data that kind of supported one way or the other, back and forth, but when it comes down to it, they're very similar. And with the Pedra on the market, you heard much about the Pedra?
No, only just today.
Just today? Well, I'd love to go through it with you and cover some of the key points, because it does have some uniqueness that really can benefit your patients in your practice.
Okay.
And obviously a mealtime insulin is usually the last resort.
Right.
And we know it's the most important resort according to DCT and D-code and UKPDS, how important it can be. Basically with the Pedra, we're looking at your type 1 patients and your type 2 patients. And typically your type 2 patients are obviously obese, and that's the majority of your practice. With the Pedra, it has a unique ability to get into the bloodstream faster than the other rapid-acting analogs, specifically Lispro, as you mentioned, that's your primary insulin of choice.
Right.
And we just recently, within the last few years, we started realizing that there's been a high correlation between a subcutaneous layer of fat, the adiposity, and how insulin is affected by that adiposity. And the unique thing about Pedra, because it's a smaller amino acid, it has the ability to get into the bloodstream faster. And what I mean by amino acid, it just basically, the other rapids are hexamers and monomers, and basically hexamers and dimers, where this is more of a monomer and dimers. It's just really a smaller unit.
Okay.
So that really gets in there quickly. And truly the benefit for that for your patients was basically we looked at BMI in specific populations in non-diabetic patients, and we looked at ranges from 25 to 35 and greater. And really why we looked at patients that were non-diabetic, which you're probably thinking, why non-diabetic patients? We looked at them because they don't have any factors as far as insulin resistance is concerned, and so you really don't have to make any dosing calculations. You'll get a true response. But at every single endpoint, when we compare it to Lispro, we outperformed with regards to rapidity. And as you can see, a Pedra measured in blue, and in orange you'll see the Lispro. So really what that means for your patients is when they eat, they're going to get that mealtime coverage that they truly need right away. And that's obviously, I would imagine, and you would tell me if I'm wrong, but that's usually typically why we use these mealtime rapid insulins, because of that physiologic aspect.
Now, what is the actual time difference?
Well, you can see it's not a huge time difference, and that's pretty much a common concern for physicians. Like, Sean, you're showing me this, and it looks like there's really not that much of a difference. But as you can see, as the BMI starts to increase, which typically happens to all of us, we usually gain weight as we get older, and even more so because of complacency with your type 2 diabetics. That you can start to see a really major difference, when you're looking at 35 or greater. And I would say that's more of a true response of those patients that you're having problems with regard to insulin. So, it may seem like a small difference, but it's still a big difference when you think of the course of a lifetime of your diabetic patient. Obviously, in my opinion, and take it for what it's worth, but the sooner you can get control of your insulin with your glucose, the better benefit that will help you in the long run. And we know that diabetes is a progressive disease, and I think, there's really not many differences when you start looking at other rapids compared to each other. It's usually a small difference. Like with Lantus, as people know, it has some similar benefits as NPH, but obviously the titration and other issues make it a unique and obviously the #1 prescribed insulin. But with regard to absorption, I think that's one of the key aspects of a Pedra, is it has the ability to get in the bloodstream. And how we measured this, we looked at glucose infusion rates, again in non-diabetic population, and when we had a response with the Pedra, you can see the line measured in blue. It's kind of a biphasic response, and it almost looks like we flipped it around compared to what Lispro does. So you're going to get a higher peak area of coverage as far as insulin to your glucose, and you're going to be out of the system relatively as fast as what you're currently seeing with your Lispro. So that's why we're seeing faster onset of action. So when your glucose levels go up, we can really recreate that first phase endogenous insulin response as represented here from the New England Journal of Medicine. In your type 2 patients, it's a delayed response. Obviously in your type 1s, they don't have any insulin, so that's where they're not going to have this whatsoever. But that's where this advantage is because of that, the rapidity, the ability to get into the bloodstream a lot quicker, it's going to benefit your patients. So I think that's kind of critical. And if you look at the confidence interval, when you compare this to Lispro and regular human insulin, you can see that it's a significant confidence interval. So does that seem like a benefit thus far with regards to using a Pedra versus Lispro?
Yeah, right at this point, yeah.
Okay, good. We also have dosing. I think dosing obviously is unique. How do you currently dose your patients?
No, there's not really a formula.
You know, you could, some people do this sliding scale if they're coming out of the hospital. You could do the carb ratio, but whatever you're currently doing, you can do the same exact way with the Pedra. You can just, if someone was you're not seeing the results you'd like to see with the other rapids, you could just switch them over unit for unit. Some of the educators will actually do 80% of the insulin dose that they're currently on and then titrate up so that they're not having any risks associated with hypoglycemia. But the nice thing about a Pedra is you have a flexible dosing window. And what I mean by flexible is you can take it 15 minutes before, like the other rapid-acting agents, but you can also take it up to 20 minutes after a meal. And I think that can be critically useful for patients where, do you have patients that you suspect are probably not adhering at the proper times?
Right.
So I think that's an area where it may be a benefit. And whether you're comfortable with 15 minutes before, at least you know that there's efficacy pre and post for your patients. So whether they do take it 20 minutes after or 15 minutes before, you're going to have the confidence that they're going to get the coverage and obviously the A1C reduction that you're looking for. Now, I'd like to cover A1C with you because obviously that's the only way you can truly get a response as far as success with your patients. Unless they're saying they're feeling good. I mean, that's always good too to say, hey, I'm feeling a lot better, doctor. But when we looked at type 2 diabetics in a study that was actually done by Dr. Daly, and Dr. Daly is out of the Hoya Scripps Clinic in California, and this was done in diabetes care. And basically what Dr. Daly found in this study of 2004 in October, he actually has a pretty good insightful information here. It's the largest study ever designed. I thought that was kind of surprising because you think of how long we've been working with insulin, 1932 when they first really invented it. There hasn't been any real large clinical studies around intensive therapy with a rapid-acting analog. Well, Dr. Daly and his associates, they have a really unique quote in here because we're talking about efficacy. And I don't know if you know this, but I didn't know it either. When I used to sell Lispro, and it does say it in their PI, but they show no clinical significant difference in A1C reduction versus regular insulin in type 2 diabetic patients. Now they do have data in type 1 where they are showing reductions, but we know there's a clinical difference between the two. But he actually states right here, which I think is kind of unique, he says, the greater the baseline endpoint reduction in HbA1c observed with glulisine versus regular human insulin in this study was small and statistically significant. Although the clinical relevance of such a difference remains to be established, such a difference has not been established previously in other type 2 rapid-acting insulins. So that's kind of critical. When we think about these agents, we know that we're using them obviously for physiologic aspect, but it's good to know that when you look at patients for type 2, you're going to see a difference as far as A1C reduction. So we found in the studies by Dr. Daly a 0.3 reduction with regular human insulin and only a small difference, 0.46. But as I mentioned earlier, it is small, obviously, but that's still a big benefit in the course of a lifetime patient. So I think that's unique. What do you think about that?
I mean, it seems like such a small percentage.
It is. No, it really is a small percentage. I mean, you're talking 0.16.
Right.
But 0.16 is better than 0.30. So, and if someone's, the tighter the control,
Mhm.
the less micro and less microvascular complications you're going to see. And that's supported, as we talked about earlier, UKPDS and DCT and DCODE study. So, and obviously, if you can get your postprandials down, you're going to totally reduce the risk of that cardiovascular mortality that is associated with high insulin levels or glucose levels. So that's the type 2 data. Now, if you're thinking about our type 1 data, Dr. Satish Garg out of Denver, he's at the Barbara Davis Center in Denver. They did our type 1 data, and he actually has some unique aspects in here. If we have time, I'd love to go back and cover it with you. But the more important thing was A1C efficacy. When we compared it to Lispro, which you said that you currently do use, it does show equal potency versus Lispro, so that's good to know. We are at the same level as far as control for your patients in those type 1 diabetics. And so that's from Dr. Garg, and it was a 20-week trial study, and I think that's kind of unique too, because if you look at the patients, there was 653 patients in there, and do you see that as a valid? And these aren't the obese patients. These BMIs are 24.99, so roughly around 25. So that's a little bit more of a healthier patient, which is typically what you would see in a type 1 patient, correct?
Right. Now this is just looking at hemoglobin A1C.
Yeah, just
Okay.
A1C.
Okay.
Now, do you deal with any pump patients or anything of that nature?
Not really.
Okay, well, I won't cover the pump
Yeah.
data, but we do have some that we are comparing to versus Aspart, which is Novolog.
Okay.
And that's kind of critical because Apidra is the only rapid acting on the market that does have data versus all agents on the market when you think of the other 3 that are out there. But one other thing that I'd like to mention, and I mentioned to you earlier, and Dr. Gard specifically states it, and I will leave this with you if you'd like to review it. But when we start thinking about absorption, Dr. Gard explicitly states in there that there's a possibility, due to the fact of the matter that you're able to get into the bloodstream a lot quicker, you're able to reduce the load of insulin that you may need, obviously because you have to push your insulin dose with the other rapid actins, because a lot of the ability to absorb is taken up by the idiopectin. And so I think that may be critical, because if you have someone who thinks they're failing and that they're having to push their insulin dosage, that may be an advantage for them where it's able to reduce that load. And he specifically states that in an article where that may be a possibility for someone that may be having that type of issue. So, do you happen to have any questions around Apidra where it may hold you back from prescribing it for someone who needs multiple daily injections?
Well, how has it been accepted on most formularies at this point?
It is available on Medicaid. If you see Medicaid patients, it is available on Medicaid.
Okay.
And we are, in some areas, it's available in Blue Cross, depending on where you're at.
Okay.
For where you're at locally, I honestly don't know your managed care situation, but I could find out and get back to you with it.
Okay.
But we do have patients' assistance available too for those that can't afford it. So.
Okay.
But I just would like your commitment, if someone does come in and you're looking for some clinical experience, that you give Apidra a shot, because I really think the data is supportive of what it will really resemble in the real world.
Sure. If it's feasible, I'd consider it.
Okay. Well, I'd love to hear about your experiences with it and get some feedback. So real world to clinical sometimes doesn't always relate, so I'd love to see how it works out in your practice.
Okay.
So,
well, thank you very much.
Yep, thank you very much. So we gave you the full detail on
You
Apidra.
did. That was the most anyone has all day.
You know,
That was really
I
good.
love this product.
Yeah.
I mean, I used to sell Humalog for
I can
years,
tell,
and
yeah.
I think there is some clinical advantages to it. So.
I like that you tried to bring in some pharmaceutical background on it. And were you in pharmaceutical?
Well, yeah, I did. I worked for Lilly for several years, and then I went into medical for a while and worked at plastic surgeons, and then I came back to pharmaceuticals for family. 'Cause
Right.
You know. But,
Yeah, it's really thorough. I liked these other articles because the other representatives haven't brought that in.
Yeah.
So that was good. No, overall it's really thorough.
Okay. If I had more time, I would
Mhm.
probably try to talk to you about the OptiClick.
Okay.
And because that's an advantage because of the
Right.
tighter titration that you really can get with it, and obviously the flexibility, because it is nice to have something that will be a little bit flexible for your patients, but
Right.
real importantly is if you can't get an accurate dose, it really doesn't matter then, so you get more
Right.
accurate dosing. But so.
I think I would say this figure though, it doesn't really give me much information. But,
Oh, the data
Yeah.
around here.
Mhm.
It's this is something most reps aren't confident enough to talk about.
yeah.
But that's why I just put it as a fair playing field, because if you are currently comfortable, we're not saying we're greater than Lispro, but we're saying we may have a clinical advantage. And I'd like to show some fair balance, because obviously, if you show something, you can always show one side of the picture.
Right.
But I really feel that you need to show both sides to validate you as a true professional in whatever you do.
That's fair.
So,
Okay.
excellent.
Good.
Well, it was a
Thank
pleasure
you.
meeting you.
Nice to meet you too.
Thank you very much. Are you from the area out here, or did you relocate?
No, I'm from here.
Are you
New
from
Jersey.
here? You have children?
No.
No, I'll tell you, man, I got a little girl, she just had her first birthday on Tuesday,
Oh, wow.
which I was real sad daddy. I'll show you, I'm such a proud daddy, but, I got this new phone, but you can see right here, this is so neat, there's my little one right there.
Oh, she's adorable.
And she's moving around, she just got her little noisemaker, she loves like making noise, she's like, ding, 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 ding. And I'm like, oh, I wish I could just watch you do that all day.
She's musical.
Yeah.
She's musical already.
Yeah. My little honey.
Fantastic. Are you
Thank you.
from this area?
I'm actually from Michigan.
Oh,
I live
okay.
in Colorado, but I'm originally from Upper Michigan, the UP,
Okay.
which is kind of next to Lake Superior.